Welcome to the Global AMR R&D Hub's interview series, AMR Snapshots. I'm Leslie Ogilvie, a Scientific Programme Officer at the Hub. Today I'm very happy to be speaking to Dr. John Rex, a physician and drug developer with more than 30 years of development and policy experience focused on antimicrobial agents, and generally just a leading voice in this area. He's currently the Chief Medical Officer and Director of F2G Limited, a company focused on developing priority antifungal agents. So welcome to AMR Snapshots, and many, many thanks for joining me today.
Sure, happy to be here.
Today we're going to talk mainly about a recent report published by the Hub on the market potential of new health technologies addressing AMR. And you were kind enough to publish a newsletter on this quite recently. But to start off with, I just really want to ask you a little bit about your motivation for being in this field. You've been working in this field for over 30 years, developing new antibiotics in both the academic and professional industrial area. And you're working now as a consultant, spreading information about the challenges of AMR via your AMR.Solutions YouTube and newsletter series, as well as your fireside chat series of interviews. And you ask many of the figures in your interviews, what drives them to work in this area. And I just wanted to sort of put this back at you, what keeps you interested? What motivates you to do this?
Fundamentally, I'm a doc. And I got interested in the problem of antibiotic resistance when I was on the faculty at Houston at McGovern Medical School. And I was the epidemiologist for our hospital. And the first time I saw this was a young lady who had a bunch of burns, and she wound up with a Pseudomonas infection where the organism could really only be treated with a flamethrower. And the only thing that made her survive was she was young and she was tough, and we scraped together a bunch of drugs and gave them to her at high doses, and she withstood that. It actually ended up working. But it was the first time I'd ever seen an organism that really kind of couldn't be treated in that way. It was really quite spooky. And sort of fast forward over time, AstraZeneca makes me an offer to come and run their anti-infective group in 2003. And so we move everybody to the UK, where we end up spending 8 years. And then I'm back in the Boston area. But, all through it has been, my motivation is I'm a doc, internist, infectious disease specialist. And I want these drugs available for the kinds of patients that, I know are out there, which one day could be you or me. And I don't want there to not be the right drug.
Yeah, so it's just seeing this being on the front line of this and just seeing what antimicrobial resistance can actually do to people on that front line. Yeah. I once closed the surgical ICU for 10. Closed the ICU because we had an outbreak of an organism then that was untreatable. The only thing I could do was mechanically get it under control, and that worked. But it meant that I told people, no, you can't do any elective surgeries. Yeah.
Planning to do a hip surgery? Nope. Need to reschedule that. And that's kind of like what's happened with COVID these days. For lack of a good COVID fire extinguisher, the world's on fire. And so not having the right drug, not having the right tools, we're so used to having them. Most of us have never seen an untreatable infection.
Yeah. The world's on fire. That's a great quote. The world's on fire.
COVID has set the world on fire. And if we'd had the right fire extinguisher back at when all this began at Wuhan, we would have had some cases in Wuhan. There would have been some outbreaks here and there in the other place, but we would have put out the fires. We wouldn't be doing this. We still want a vaccine. All that stuff would still be necessary. But we wouldn't be having all this shenanigans with what's going on with COVID right now. The world would be a very different place if we'd had the right fire extinguisher.
I'm going to move on now to the actual report that you wrote the newsletter about, the one on market potential of priority health technologies addressing AMR. So what we found in this report was that there was an astonishing mismatch between the market potential for AMR tools versus the patient need. And this is something you highlighted in your newsletter. And for the therapeutics we looked at, these were antibiotics targeting bloodstream infections and pneumonia, and reimbursement based on usage. It really wasn't covering the cost of developing and maintaining these antibiotics. Now, we see that UK has a subscription-based pilot method, and the PASTEUR Act in the US is maybe getting through Congress. We don't know yet. And these are paving the way for these so-called volume-delinked mechanisms in this space. And then, do you see this being suitable for all countries? Is this a one-size-fits-all solution?
Well, the principle is suitable for all countries. Countries may vary in how they construct it for their purposes. But the notion that you want to have the right fire extinguisher at hand and then it just sits there is the thing that you've got to wrap your head around. And we're not used to paying for drugs except when we put them into humans. Antibiotics are the weird exception. They're the very existence of an antibiotic, even if used only very infrequently, is helpful. And the thing that the UK's work did for everyone is it gave us an acronym. The acronym is called STEADY, S-T-E-D-I. And STEADY is the set of attributes that an antibiotic has even when you don't treat somebody with it. The fact that it's in the pharmacy and you could use it has an intrinsic value. And of the 5 attributes, T, transmission, is, I think, arguably the easiest one to understand. If you have a bad infection with a highly resistant bacteria and I treat you, you can't, 2 things happen. You get better, but also you can't give it to anybody else. So there is, having treated one person, 50 people benefit. If they take the COVID example, if I had COVID, but I took a drug and I treated it, then nobody else, I don't spread it. So there's value to the other people around me that they don't, and they don't pay, in typical models, they don't pay for that. But they benefit from the fact that I'm no longer on fire and I'm not spreading the fire to anybody else. And the UK spent a lot of time working with NICE, the world's preeminent health technology assessor, thinking about what you had to do to measure the non-use values that an antibiotic brings, the values in existence. And so they have articulated that for us. They said it's real. And so the UK's pilot project is about saying, there's some tools we need to have in the pharmacy. And we need to buy them in advance so that they're there. And we need to pay for them to have them there. But we don't plan on using them very much. And we want to experiment with how to do this. So that's the great thing that the UK pilot has done for us, is they've laid out a way of thinking about what kind of antibiotic should you buy, and we're about to see their report on how they really value it, precisely what value they're going to assign. They put a notional value down of 10 million pounds a year for 10. And that was a bit of a finger in the air sort of a guess, but it's actually turned out to be a pretty good number. That value range. And my colleague Kevin Otterson has a paper about to come out where he's really, really worked the problem to great detail. And he's figured out kind of what the target value ought to be. And the UK's number is a good, we actually wrote one of our newsletters that the UK number says, take their 10 million pounds times 10, let's scale up to dollars. They're saying it's $4 billion is the value of a good fire extinguisher for the globe. And that's actually right on target. That's the value to the globe of a good fire extinguisher.
So it's really just about implementing it in the different countries and how each country can adapt to this model, in a sense.
Yeah, there's that word, just. Yeah.
Yeah, just.
Well, and there's a lot that has to be done, and you have to the techie geeky crowd, you and me. Can say that we need this, but you actually have to convince a bunch of other people. You got to get to where we can talk about it in a way that a minister of finance, and that's been a big step forward for us over the past 10 years. Really, we've gone from being techie geeky focused when all this began to developing language that speaks to the economists, that speaks to the finance people. And that's, the fire extinguisher is one example of it, but we also, I can't be an economist, but I can sort of pretend to be one briefly, and I can talk about, the different kinds of market failures and exactly what we've got here. And we've done a lot of modeling that helps people understand that, yes, in fact, I know it sounds weird, dear finance minister, but in fact, by buying this fire extinguisher, you actually protect your population. And COVID's been just a great tool for explaining that to people. I mean, we often come back to the model of, if we had a fire extinguisher for COVID, it would have been, the world would be very different, and a few $100 million worth of a COVID fire extinguisher would have protected the world. At this point, we've lost trillions of dollars of value and a lot of dead people because we didn't have the right fire extinguisher.
I'm going to move now from therapeutics to diagnostics, so it's for the other side of the coin in a sense, and our report highlighted an equally bleak situation. So in this case, it wasn't about the volume, it wasn't a volume-based issue, but due to the uptake, it's just diagnostics can be quite expensive, and it's creating costs that are higher than the cost of actually just treating empirically. Is there a clear path forward? Is this a dilemma that we can ever solve? I mean, in certain countries it will be, but globally.
It is an issue that doesn't have a single simple solution. And you talked about the cost. Let me just say, cost is more than money.
Yeah.
So if somebody and you've also got to think about the costs, sort of the different settings of the world. Doing a diagnostic, I've got to pay for it, but I've also got to do it, and that takes some finite period of time. And so some conversation I was in recently was talking about the fact that it's in the clinics and some of the more impoverished parts of the world. The main thing they want to do is get through the queue of patients who need to be seen today, so that everybody can go home before it gets dark, so that it's safe to walk home, because they're not in a place where it's actually safe to be out after dark, because they're, threat like wildlife threats, for example. They need to be done by the end of the day. And so if a diagnostic even takes, 20 minutes, it's easier just to give you a prescription and go. It is. And so diagnostics have a tricky balance. And also diagnostic always costs, or it seems to cost more to include a diagnostic. Now the question is who's paying for that. And this is where we get into siloed budgets. If the drug budget and the diagnostic budget are in different places, then you've got misaligned incentives. And so this question of how do you articulate the value of doing a diagnostic, and go back to the idea of steady. What are the steady-like values of doing a diagnostic? And we've not articulated that for ourselves as a community yet. There's actually a project is ongoing right now that is, I believe the name is Drive DX. It is a project that is doing for diagnostics what Drive AB did for antibiotics 2014 to 2017. It's saying, what's the value? How do you talk about it? How do you summarize it for other people so that we can deal with all the stakeholders who have to rearrange their brains about why it's important to use a diagnostic?
Yeah, I think it's really the value of things and the bigger picture of the value, in the long term as well. I think this is never taken into account. It's always short-term thinking, political short-term thinking, maybe.
Because that's easier. I mean, I don't think there's nobody who's being malicious about this. There's no ill intent. We're just talking about how we are as human beings, and also kind of how much data you've got at any given time. And life is what it is. Life is complicated. Life is messy.
Our report also highlighted the fact that we need additional support and or implementation of new models in addition to the use of these traditional policy levers. So like you say, it's messy, it's complicated. We're not going to have one thing that's going to work. Do you think it's realistic to have all these different things acting together? And if so, do you think there's a time frame? Do you see this happening? Is it feasible?
This is arguably less complicated than climate change.
Yeah.
And we actually can, we're seeing things happen that are directionally correct. And it's helpful just to realize that in how far we've come in the last 10 years. The first conference that dealt with this was in 2009. The Swedes were the presidents of the EU in the last half of 2009, and they convened a groundbreaking conference. The title was something like Innovative Incentives for New Antibiotics. We were talking about incentives for antibiotics, and the government was talking about how do we get the pharma industry to make new antibiotics. No one had ever talked about that in public before. IDSA had been talking about bad bugs, no drugs, and we need new drugs. Yeah. But new drugs don't appear by magic. It takes a lot of time and effort to create. How are we going to do that? And at that time, 2009, we didn't have any of the tools we have now for language. I was there at that, and it led to creation of TATFAR, the Transatlantic Task Force. It led to the EU having their big declaration that they would do something, which led to the creation of the New Drugs for Bad Bugs initiative under the auspices of IMI, which led to 7 projects, and buried in that was Drive AB in its language, but also the UK got busy, and Lord O'Neill ran his team to write the AMR review, and Dame Sally discovered her lobster analogy. And then the UK, nice. So in 10 years, we've gone from 0 to really kind of a big body of stuff and a lot of stakeholders and a lot of non-techie stakeholders who are involved. Pasteur is a really good example of that. In the United States, politicians have lots of things to worry about. There's many things going on. But we have now, because of Pasteur and because of the work that's been done to produce it over time, the GAIN Act in 2013 got a lot of politicians educated about antimicrobial resistance. And then Pasteur has been banging along now for a while, and they socialized it last fall in the last Congress. And now it's really seriously going forward. And what it means is a lot of politicians who spend time going, they're not docs, it's not their area, but they've taken the time to learn enough about this, and they understand it, and they think it's important, and that's what's going to move the needle. The U.S. does that. I'm seeing Canada doing it. We're seeing Japan make some interesting noises. Europe, the European Pharma Strategy talks about we need pull incentives in Europe, and they're actually starting some projects right now. A newsletter recently talked about how anybody who wants to can be applying to help work on these projects to build the framework for how the EU thinks they should do pull incentives. Yeah, I think it's doable. And the magic sauce is that we've expanded the conversation box to the range of stakeholders. Drive AB kind of helped us find them all. And we've got some great non-technical political thinkers who understand the area and who are pushing it. So I think it's doable.
We're talking about action. You're very vocal about it's time to take action now, basically. We have a lot of knowledge, we have a lot of reports, there's evidence that there's evidence there that we need to take action now, and we have the tools to do it. So in terms of concrete action, what would be on your wish list?
Well, it's not one thing. It's this whole collection of folks who are steadily beating the drum, and I think that having the message be visible in a variety of venues is this art of communication. Is the thing that's why I write a newsletter now. I mean, I never meant to write a newsletter; it just kind of happened. But at this point, I correspond regularly with 2,500 of my best friends around the world, and by providing the language and by having all of those people know how to tell the story to their 2,500 best friends, that you actually make a change. Individuals can make a real dent in this by telling the story at the right time and explaining it. AMR has got some complexity to it. It takes a little time to wrap your head around it, and particularly the idea that you should pay for a drug you're not going to use. How do you square that? Well, and then that's where the fire extinguisher analogy comes. And we pay for fire extinguishers, and we hope not to use them. My other version of that is life insurance. Do you have life insurance?
I don't actually. No.
Oh, well, okay.
Yeah.
Well, I do, and my life insurance didn't pay off today. And I will tell you that I am not at all distressed about that, and I will continue to pay my life insurance. Happy when my life insurance doesn't pay off. So there are things that we buy to protect ourselves, and preparedness is just boring. Let's be honest, okay? Doing stuff to prepare for an event that might not happen and actually doesn't happen is dull. And yet, the instant you don't have that fire extinguisher, man, oh man, it has infinite value right then on that spot. And learning to talk about that in ways that aren't techie geeky has been just so powerful for all of us.
No, I agree completely. I think communication is key, and communicating in languages and metaphors that everybody can understand. I think that's key to progress in any field in the end. So it's a very short dive. We try to keep this quite short. So I'm going to squeeze in an extra question on a topic that's close to my heart, and it's a bit of a tangent, but something I'm really curious about, and this is your opinion regarding alternatives to antibiotics, such as bacteriophage and non-traditionals, and how we can work these in combination or replace antibiotics in specific cases.
So I'm going to give you two answers. One you'll like and one you won't like. So the part you'll like is that some some non-traditional alternatives have really cool science. I think you take, for example, therapies that are designed to boost your immune system. Scientifically, I love the idea. Technically, it's very interesting. That's the part you'll like. The part that you won't like is that developing those approaches in a way that is useful is almost impossible. And the reason you can't do it has to do with the nature of infections in general. Let's pretend that you and I invent a drug that improves immune function, and it's our hypothesis that we're going to reduce the mortality in patients with nosocomial pneumonia, people who wind up in the ICU on the ventilator, bacterial infection. The mortality rate in that group is about 20%. And so you and I say, well, okay, here's our drug that's going to improve immune function. And we're going to we're going to reduce the mortality rate. Well, if you actually start picking at a study like that, the mortality rate is 20%. Of that 20%, I will tell you that about half of those people are going to die no matter what you do. There's a certain amount, they had so much trauma, there's some portion of it that you can't improve on. So the group in whom you can make a difference is that last 10%. And now what you've got to do is move the mortality rate it's always going to be at least 10%. What you're trying to do is bring it from 20% to 15%. When you do the math on that, the study size is enormous. So in theory, you could do the study, but in practice, it's really hard to do it. And what if you demonstrated the mortality rate went from 20% to 18%? Is it really worth paying for? And that's the problem. It's that current therapies are actually pretty good. And in a study like that, neither arm can be a therapy we think won't work. We've got to make both arms of the study because infections kill you. So both arms of the therapy have to be good. And good therapies, they work. And it leaves you with only a little bit of space to improve. Now that's for the things like immune answers. Phage, on the other hand, you ask about phage. A lot of people ask about it. Phage intrinsically work like any other drug. I mean, in the sense that they kill bacteria. Boom, gone. So if you can come to make a phage cocktail that has the speed, potency of penicillin, there's no reason you can't develop it as a drug, provided you can make it every time you need it. And that's the problem with phage. Is penicillin's always the same thing. There's two penicillins, the same molecule, molecular weight, blah, same thing every time. Phage is not the same thing. You different cocktail stuff. So how are you going to make it so that Dr. Busy can say, I'd like some, and you say, here it is, and that works reliably? If you can solve that, phage can become an approved therapy. there are a couple of companies that I think might deliver phage as an approved therapy because they're taking this really systematic approach to big refrigerators, freezers full of lots of different phage and a quick way to pick out, I want to mix this one, this one, and this one, and this one, and that one. And that's you, go. And quickly. If you can do that, you've manufactured a drug and you've demonstrated how to manufacture it. You've demonstrated how to select the patients, and that's approvable.
Yeah, I think there's definitely a lot of promise in this field, and I think we just got to find the right solutions for it. I think we could learn from maybe personalized medicine, different sectors where we can start thinking a bit differently.
Yep. Personalized medicine is a great hope. It's also tricky at a regulatory level because there's a lot of stuff you have to do to define exactly how do you personalize it and do it in a consistent way. But it feels like those technical issues are resolvable. It's I would like to see phage therapy get approved. I think it's clearly it kills bacteria. Those photomicrographs are fantastic. Poof, it's gone.
That's a great place to end, I think. I just really want to thank you for taking the time to join us today, for your insights and your expertise. I just want to highlight that the Market Potential Report and associated policy briefs are available from the Hub's website. And thanks again, John, for your time.
Yeah, thank you. It's fun to chat with you. Thanks for the good report. That sort of policy-based stuff really helps drive messages home. Good.
Yeah. Thanks a lot.
Work. Thank you.
Okay, take care.
See ya.
Bye-bye. Bye-bye.